We are going to talk about the veins and the venous disorders. My name is Mohamed El-Maadawy. I am a professor of vascular surgery in Cairo University. First, we are going to talk about the varicose veins, starting by the anatomy of the veins of the lower limb and the venous return. There are three forms of the veins, or three sets of the veins in the lower limb. These are the deep veins, the perforator veins, and the superficial veins. They are named according to their relations to the deep fascia, whereas the deep veins are deep to the deep fascia. Superficial veins are superficial to the superficial fascia, and the perforator veins are traversing the fascia to convey the blood from the superficial to the deep veins. The superficial veins, we have the great saphenous system and the short saphenous system and the communicating veins. The great saphenous vein starts as the medial end of the dorsal venous arch of the foot. It ascends upwards in front of the medial malleolus, on the medial aspect of the leg, medial aspect of the knee, and on the anteromedial aspect of the thigh to a point 4 centimeters below and lateral to the pubic tubercle, where it pierces the deep fascia to join the common femoral vein through what's called the saphenous opening. And this site is guarded by a valve which prevents the passage of the blood from the common femoral vein to the superficial veins, which is the great saphenous vein. Similarly, the small saphenous vein or the lesser or the short saphenous vein starts as at the lateral end of the dorsal venous arch of the foot. It ascends behind the lateral malleolus upwards right into the posterior aspect of the leg until it reaches about the popliteal fossa, where it pierces the deep fascia to join the popliteal vein. Here is another valve which controls the blood, allowing it to pass from the short saphenous vein to the popliteal vein all the time, and it prevents its passage in the reverse direction. This junction is called the sapheno-popliteal junction. The third set of the superficial vein, the communicating veins, which are numerous, and they communicate this short saphenous system with the long saphenous system, and many of them possess valves as well. The deep veins are corresponding to the arteries, and they are giving the same names as the arteries do, and they are present in close proximity to the arteries. Here in the leg, we have two anterior tibial veins, two peroneal veins, and two posterior tibial veins. These join together to form the popliteal vein, which ascends upwards, and it becomes the superficial femoral vein in the thigh, which ascends upwards to near the groin, where it joins the deep femoral vein to form the common femoral vein. These deep veins are possessing valves. These valves are bicuspid valves, which allows the passage of the blood in only one direction from below upwards, and it prevents the passage of the blood in the reverse direction as shown in this diagram. The third set of veins is the perforator veins, which are traversing the deep fascia, conveying the blood from the superficial system to the deep system through a natural aperture present in the deep fascia. These veins also are possessing valves which are unidirectional valves, allowing the passage of the blood from the superficial veins into the deep veins and prevent their passage into the opposite direction. The venous return and the calf venous pump. The venous return is not a passive process, it is an active process, and it depends upon three components. The first is the pressure gradient between the thoracic and abdominal cavity and the lower limb veins. The second is the transmission of arterial pulsations onto the venous wall, thanks to the close proximity of the deep veins and the deep arteries, where the pulsations of the arteries are transmitted to the wall of the veins and aiding in the passage of the blood in this upward direction. More important than the above two mechanisms is the muscle pump, which is termed the peripheral part. This muscle pump is formed of three components: the calf muscles and the deep veins possessing competent valves, together with the perforators, which also possessing deep, which are possessing valves. All are enclosed in the deep fascia. When the muscle contracts, they squeeze the deep veins, and the blood inside is forced to go in an upward direction. The presence of the valves prevents the reverse passage from the deep veins to the superficial veins. When the muscle relaxes, the blood is sucked from the superficial veins along the perforator veins into the deep veins. The presence of the valves inside the deep veins prevents the regurgitation of the blood from above downwards, maintaining the unidirectional flow from below upwards. When we are going to talk about the varicose veins are, as you know, are dilated, elongated tortuous veins present in the lower limbs. They affect 10% of people, mostly affecting females, with the female to male ratio is about 4:1. They are either primary varicose veins or secondary varicose veins. The primary varicose veins could be attributed to paucity of the valves inside of the veins, or the veins are present in a good number, but they are congenitally incompetent. Also, there may be weakness of the vein wall, like what happens in the what's called the generalized weakness of the mesenchyme. This generalized weakness of the mesenchyme leads to weakness of the vein wall, which cannot withstand the normal pressure inside of the vein, and the vein would dilate in front of the normal pressure inside of it, and the varicose veins results. Pregnancy leads to primary varicose veins by several mechanisms. First of all is the hyperdynamic circulation together with hypervolemia due to salts and water retention caused by the pregnancy hormones. Added to it is the pressure of the gravid uterus over the pelvic veins and over the vena cava as the pregnancy advances in time. And lastly, the relaxing effects of the pregnancy hormones that leads to dilatation of the veins. Hormonal contraception works in similar but to a lesser extent than pregnancy in leading to the varicose veins due to salts and water retention and their relaxing effects on the wall of the veins, and also the hormonal replacement therapy works the same way. The secondary varicose veins are caused by factors or pathological conditions that affect the veins in the following way. DVT can be complicated by secondary varicose veins due to destruction of the valves inside of the veins after recanalization of the thrombus, which occurs on acute DVT. Second is the pelvic tumor, which could compress over the vein and resulting in secondary varicose veins. And lastly, the arteriovenous fistula, either congenital arteriovenous fistula or traumatic acquired arteriovenous fistula, whereas the arterial pressure is transmitted to the vein. Subsequently, the veins will get dilated, engorged with blood, and becomes varicose as well. The presentation of the varicose veins in most of the cases, most of the patients are presenting with heaviness and discomfort. These heaviness and discomfort are well felt in the foot and in the ankle towards the end of the day, particularly after prolonged standing or after exertion. Also, edema of the foot and edema of the ankle and pain along the affected vein. Pain along the affected vein has its own mechanisms. It results from recruitment of the nerve ending upon dilatation of the vein, and this is perceived by the patient as a pain along the affected vein. Most of the patients are coming to seek medical advice owing to the aesthetic concern of the unsightly veins in their lower limbs, particularly. Most of the patients are female patients are usually over concerned to their appearance. There is small proportion of the patient that those patients come complaining of complications of the varicose veins, namely the ulceration, pigmentation, and dermatoliposclerosis. On clinical examination, we have sets of tests that are now considered to be of academic interest only, but we should have an idea about them. But actually, in the diagnosis of the varicose veins and the subsequent management, we do not rely to some extent on them, because they are usually not accurate, and maybe their sensitivity is much lower than the duplex, as we are going to see. On clinical examination, we have to examine for the presence of the groin lymph nodes, and if they are present, we should describe them in order to see their characters and the cause of their enlargement. And also we should describe the ankle ulcer once it is present, to see if there is an edema, which type of edema is pitting or non-pitting edema, and its extension. Also redness and tenderness along the veins of varicose involvement, to pick up if there is thrombophlebotitis, which is a frequent complication of the varicose veins. Also the presence of the dermatoliposclerosis. In all of the patients who are having lower limb problems, we should palpate the pedal pulse to see if they are present or not. Evidence of arteriovenous fistula could be uncovered through finding of the thrill over the affected veins and hearing by the stethoscope of a puree along these veins. This puree usually is machinery murmur. The last thing in the examinations is to see if the muscles of the calf are working well, and the ankle joint is free of constraint from movement. In evaluation of the patients, we have to have history taking, good history taking, either this problem, when this problem had happened, and what is its progression and what is affecting the patient, and to have an analysis over the pain and the course also of the ulcer if it is present. Together with the clinical examination we have given before, we have what's called the plethysmography. This plethysmography, before the developments in the duplex ultrasound, was to diagnose the presence of these varicose veins by finding the change in the volume of the lower limb in relation to the venous flow. It had been supplanted by the duplex ultrasound. This duplex ultrasound gives an idea about the patency and integrity of the deep system, together with its competency and competency of the saphenofemoral junction saphenopopliteal junction and presence or absence of incompetent perforator, and where exactly they are located. We have treatment options. These treatment options is number one is decompression therapy by hosiery. Either it is knee length or it is waist length. The knee length is called the below knee elastic stocking, and the waist length is called above knee elastic stocking. They are of varying degrees of pressure compression. The class 1 ranges in pressure from 20 to 30 millimeter mercury, class 2 from 30 to 40 millimeter mercury, and class 3 is from 40 to 50 millimeter mercury. The class 2 is the commonly used in the event of the varicose veins. Comes next is the injection is sclerotherapy, and its idea is to lead to sticking of the wall of the veins together. Therefore, there will be no lumen for the blood to go through. It eliminates the patient from the presence of these varicose veins. Lastly, the surgical interventions are reserved for the patient whom did not tolerate the compression therapy or the injection sclerotherapy or failed this conservative treatment. Surgical interventions are two types: saphenofemoral disconnection with or without saphenous vein stripping, and more recently the saphenous vein ablation, either by radiofrequency ablation or laser ablation or a chemical mechanical ablation. This is example of the techniques of the injection sclerotherapy. As you see, this is the vein which should be ablated by this sclerotherapy, and this is a butterfly inside of the vein, and this is the scleroform to be injected in order to stick the wall of the veins together. The surgical intervention, we have the high ligation of the saphenofemoral junction through an incision placed in the inguinal crease, and the saphenous vein is ligated. Then a vein stripper is introduced through the saphenous vein at the knee, and then after it is tightened up, the vein is stripped out. This is a phlebectomy, which is performed in conjunction to the conservative management or as standing alone. It can be performed under local anesthesia. Several small incision, each is 2 millimeters, can be placed. Then a hook is introduced in order to take the vein out, and then the vein is avulsed until it is completely removed from the affected segment of the lower limb. Here is the laser ablation, where the great saphenous vein is accessed at the knee, usually under ultrasonographic guidance. Sheath is introduced into this vein. Through the sheath, the laser catheter is introduced until it reaches just below the saphenofemoral junction, and then the laser energy is fired in pulses as the catheter is withdrawn downwards until this generated energy leads to heat and denaturation of the vein wall, which will stick together, and the saphenous vein is ablated without removal or extirpation of it outside of the body. This is the end of our, and we in the next lecture we are going to talk about the superficial thrombophlebitis. Thank you for your attention.